So if you take platelet-rich plasma, right, and you inject it just a few millimeters into the surface of the vaginal wall, I mean, it acts like this absolute medical marvel. It's almost like turning back the clock on the tissue.
It really is. But if you take that exact same needle, that exact same biological material, and you push it just a few inches deeper into the pelvic floor muscles,
It completely fails.
yeah, it completely fails. It goes from being this highly effective, scientifically validated therapy to, well, essentially doing nothing at all.
Which is wild. Welcome to the deep dive, by the way. Today we're looking at this massive blind spot in the regenerative medicine world, because if you've been paying any attention at all to like modern dermatology or intimate wellness clinics, you've definitely seen PRP marketed for almost everything.
Oh, absolutely. Hair loss, bad knees, skin rejuvenation, and increasingly gynecology.
Right. And the pitch is always exactly the same. They say, we're going to use your body's own natural healing factors to fix whatever is broken.
Hmm.
But today's deep dive is really asking a fundamental question about how anatomy dictates destiny.
Exactly. We're looking at how injecting PRP into the superficial layer, so the anterior vaginal wall sub-mucosa, how that differs structurally from driving it deep into the intramuscular levator muscles.
And to get to the bottom of that, you brought a pretty fascinating stack of sources for us today, right?
I did, yeah. It's a real mix. We've got a few clinical reviews on vaginal rejuvenation, which show those high success rates of the surface level treatments.
Okay.
But then we're pairing that against this incredibly revealing cadaver study out of Beaumont Health. And that one mapped out the sheer physical difficulty of those deep pelvic floor injections.
Which we will get into because that part is just mind-blowing to me.
It really is.
Yeah.
And then finally, the anchor for our whole discussion today is this rigorous randomized controlled trial from Universitas Erlangen. And they look specifically at what happens when you inject PRP directly into traumatized pelvic muscles immediately after childbirth.
Right. So we have the superficial success, the physical mechanics of going deep, and then the actual clinical results of doing that. So, I mean, I guess we need to start at the surface and just work our way down.
That makes the most sense, yeah.
Yeah.
Let's look at the success story first. The superficial structural layer, or, anatomical terms, the anterior vaginal wall submucosa.
And to really grasp why PRP works so well here, we kind of have to look at the lived reality of the patients who are actually seeking this treatment, right?
Yeah, because we are primarily talking about conditions like vaginal atrophy or genitourinary syndrome of menopause, which is often just called GSM.
GSM.
So when a woman's estrogen levels drop, whether that's due to natural menopause or, say, breast cancer treatments that intentionally suppress those hormones, the structural reality of that vaginal tissue changes dramatically.
It thins out, doesn't it?
It thins out a lot. It loses its elasticity, and the natural moisture and lubrication just drastically decrease.
And I think it's important to point out for anyone listening that the stakes for this are incredibly high. Like, it's not just some cosmetic change.
No, not at all.
That thinning tissue leads to dyspareunia,
Yeah.
right? Which is severe pain during intercourse. It can cause chronic irritation, micro-tearing, and just a massive decline in overall quality of life.
It's devastating for a lot of patients. And, the traditional treatment is usually just the topical estrogen cream.
Yeah.
But for a lot of women, especially those hormone receptor positive breast cancer survivors we mentioned.
Estrogen simply isn't an option for them.
Exactly. They need a structural fix, but they have to do it without the hormones.
And that is where the superficial PRP injection comes in. So let's break down the mechanics of this. The process of actually creating the PRP is fairly straightforward, right?
Very straightforward. The clinician basically just draws a small amount of your own blood, just like a standard lab test at your physical.
Right.
And that vial goes straight into a centrifuge, which spins it at a really high velocity. And this centrifugal force separates the heavier red blood cells, which sink to the bottom, leaving this kind of golden plasma at the top.
But the real magic is what happens to the platelets during that spin, yeah.
Yeah, the spinning concentrates the platelets. It gathers them into these densities that are far higher than you'd ever find naturally circulating in your bloodstream.
Because, I mean, I think most of us just think of platelets as the things that make your blood clot when you get a paper cut.
Right, the scab makers.
Exactly. But in this context, they're actually acting more like little cargo ships, aren't they? Like they're packed with these chemical messengers.
That is a perfect way to visualize it. Inside a single platelet, you have these tiny structures called alpha granules.
Okay.
So when the clinician takes that highly concentrated plasma, puts a bit of topical numbing cream on the patient,
Yeah.
and uses a very fine gauge needle to inject it just under the surface of the vaginal wall, those platelets encounter the tissue and they basically activate.
They realize where they are.
Exactly. They degranulate. They basically open up those cargo bay doors and just dump this massive payload of growth factors into the local environment.
And the sources mention two big growth factors in particular, vascular endothelial growth factor, or VEGF, right? And a platelet-derived growth factor, or PDGF.
Those are the heavy hitters, yeah.
So if you're listening to this and wondering what those acronyms actually do in the body, let's break it down on a cellular level. What exactly happens the second those factors hit that tissue?
Well, it creates this highly localized, hyper-accelerated healing cascade. So this sub-mucosal layer is absolutely packed with cells called fibroblasts.
Fibroblast.
Yeah, and you can think of fibroblasts as like the microscopic construction workers of your connective tissue.
Okay, I like that.
Normally, they're just hanging out, maintaining the status quo. But when that PDGF drifts through the tissue and locks onto the receptors of those fibroblasts, it acts like a blaring alarm bell.
It wakes them up.
Completely. They wake up, they start multiplying rapidly, and they furiously start printing new extracellular matrix proteins.
Specifically, they're producing collagen type 3 and elastin.
Right, exactly. And those are the specific proteins that give youthful tissue its bounce, its stretch, its structural resilience.
But the tissue still needs a blood supply to actually survive all that new growth, which brings us to the other factor, the VEGF.
Right, vascular endothelial growth factor. So vascular meaning blood vessels, and endothelial meaning the inner lining of those vessels.
Got it.
VEGF physically signals the local blood vessels to sprout new branches. It's a process called angiogenesis.
Angiogenesis. So it's basically building new plumbing.
Literally building new plumbing to supply oxygen and nutrients to all this brand new collagen that the fibroblasts are laying down.
Okay, let's unpack this with an analogy to really lock in how the structural environment works, because I think it helps visualize it.
Yeah.
If we think of the vaginal wall as a lawn, right?
Oh, go on.
This submucosal layer is the topsoil. And doing the superficial PRP injection is basically like aerating that lawn and spraying a highly concentrated, really potent liquid fertilizer right into the dirt.
That's spot on.
It's a shallow intervention. The nutrients immediately reach the grass roots, which are the fibroblasts. The lawn thickens up, new irrigation lines are built via angiogenesis, and the whole area becomes lush again. It's a localized, highly effective renovation.
And the clinical data entirely supports that analogy, because the architecture of that topsoil naturally thrives on cellular turnover and moisture. Adding PRP yields just remarkable results.
Yeah, the sources track this using female sexual function index scores, right?
Yeah.
The FSFI.
Right. And across the board, patients receiving these shallow injections report massive, statistically significant improvements. We're talking natural lubrication, tissue elasticity, arousal, and a sharp reduction in pain.
And honestly, the most surprising part from the clinical reviews for me was that in some of those 12-week comparative studies, these superficial PRP injections actually outperformed traditional topical estrogen.
They did.
The biological fertilizer worked better than the hormone replacement for rebuilding that specific topsoil layer.
Which is just a profound medical victory for that specific tissue layer.
Yeah.
But as you pointed out at the beginning of the deep dive, the human body is not a uniform organism.
No, it is not.
The structural rules of the topsoil, they just do not apply to the foundational bedrock.
And that brings us to the major pivot today. What happens when we bypass that shallow mucosa and we try to heal the deep structural architecture of the female pelvis? I'm talking about the levator ani muscles.
Right, and we have to completely shift our anatomical understanding here, because the levator ani muscle, or the LAM, it is not a superficial lining.
It's not topsoil.
No, it is a deep, incredibly complex, three-dimensional hammock of skeletal muscle. It consists of multiple interconnected muscle bellies, like the pubicocygus and the pubirectalis, and they stretch all the way from the pubic bone in the front to the tailbone in the back.
So this muscular sling is the structural foundation that holds up the bladder, the uterus, the rectum. It's literally the floorboards and the load-bearing joists of the house.
Exactly. And during a vaginal childbirth, that foundation is subjected to extreme, just violent mechanical forces.
Yeah, the sources noted that a baby's head can stretch these muscle fibers by over 300% of their normal resting length.
300%.
Yeah.
And that kind of overdistension frequently causes severe mechanical trauma.
Huh.
We aren't talking about a lack of moisture anymore or a slight thinning of tissue.
Right.
We are talking about macroscopic tearing. In severe cases, which are called levator avulsions, the muscle literally rips completely off its attachment point on the pubic bone.
Oh.
Yeah. And along with that, you have the stretching and crushing of the pudendal nerve, which is the electrical cable that actually commands the muscle to contract in the first place.
So, given all that trauma, the logic in the medical community was basically, hey, PRP heals tissue so beautifully on the surface, let's just use it to heal these torn muscles deep inside the pelvis after childbirth.
It seems like a logical leap.
But to do that, you have to actually deliver the PRP into the muscle. And this is where the Beaumont Health Cadaver study comes in. And honestly, this blew my mind. The structural delivery method changes so radically here, it sounds like a completely different field of medicine.
It becomes this massive logistical challenge because you can't just slap on some numbing cream and use a tiny little cosmetic needle anymore.
Right, because the levator ani is buried deep within the pelvis. So to even attempt to reach it, the researchers at Beaumont detailed this approach where they utilize a curved metal nasal cannula guide.
Right, they insert this guide into the vagina and then they thread a massive 7-inch spinal needle through it.
Wait, let me just visualize this for the listener. We started with a needle maybe half an inch long, just skimming the surface, right?
Barely scratching the surface.
And now we are using a 7-inch spinal needle that is literally the length of a standard pencil.
It's huge.
And because of where these muscles sit, kind of wrapping around the outside of the vaginal canal, the clinician has to puncture completely through the vaginal wall, push deep into the internal pelvic cavity, and just blindly aim for a specific muscle belly.
That is the exact clinical reality of this procedure. They use a conceptual clock face to orient themselves, aiming that 7-inch needle at the 1 o'clock, 3 o'clock, and 5 o'clock positions.
Just hoping to hit the target.
Hoping to hit the pubococcygeus, the puborectalis, and the deeper obturator internus muscles.
I mean, structurally, we aren't fertilizing a lawn anymore. We are taking a drill, putting on a blindfold, and drilling straight through the floorboards of a house, just hoping to hit a very specific plumbing pout buried in the concrete foundation below.
That's a shot in the dark.
How can a clinician possibly guarantee they're hitting the muscle and not just, dumping expensive PRP into empty space?
Well, that very skepticism is exactly what drove the Beaumont researchers to use cadavers in the first place.
Yeah.
They needed to see if this blindfolded drilling was actually accurate.
Right.
So they took fresh cadaver pelvises, used the 7-inch needle to inject different colored pathology dyes into those clock face positions, and then they physically dissected the pelvises to see exactly where the dye landed.
Because if the dye is in the muscle, the technique works. But if it's not, you're injecting this expensive biological therapy into nowhere. So what did the dissection actually reveal?
The accuracy was highly inconsistent, which completely validates your concern. The injections aimed at the 3 o'clock position, they generally found their target, staining the intended muscle tissue.
Okay, so 3 o'clock works.
But the distal 5 o'clock position, it was a catastrophic miss.
Really?
Yeah, the needle drove too deep, bypassed the muscle entirely, and deposited the dye directly into the fat of the ischiorectal space.
The ischiorectal space. Wait, that's basically just the deep fat padding of the buttocks, right?
That's exactly what it is.
So it's nowhere near the structural muscle they were trying to heal.
Nowhere near it. It's essentially empty connective tissue. And what makes this so compelling is that the researchers saw the error. They modified their technique on the second cadaver by pulling the needle depth back from 2 centimeters to just 1 centimeter, and they tried again.
Thinking shallower would fix it.
Right. But even with that correction, in a perfectly sterile, static laboratory environment on a cadaver, they still missed the 5 o'clock target entirely. The dye just pooled in the fat again.
Wow. If highly trained anatomical researchers are missing the target in a controlled cadaver study, just imagine the error rate of a regular clinician performing this on a live bleeding patient who is in pain after childbirth.
It's highly problematic.
But, okay, let's play devil's advocate for a second. Let's assume a doctor has absolutely flawless aim. They thread the needle perfectly, and they inject the PRP directly into the torn fibers of the levator ani muscle. Does that deep mechanical environment actually respond to the growth factors?
That's the real question. Does it actually help the patient heal?
Right.
To answer that ultimate efficacy question, we turn to the randomized control trial conducted by Dr. Fernandi Moeni and his team at Universitas Erlangga in Indonesia, because this study is the definitive test.
And they focused exclusively on primogravid women, right? Meaning women delivering their very first baby.
Correct. Women who had just sustained acute fresh trauma to the levator ani muscles.
So they have the tears, they have the severe overdistension. When exactly did they administer the PRP?
Immediately. right during the suturing of their perineum, immediately after the childbirth, while the area was already exposed and being repaired. The researchers injected either autologous PRP, so the patient's own spun-down platelets, or a simple saline placebo directly into that traumatized levator ani muscle.
And then they just sent the women home and tracked the recovery. But how do you objectively track the healing of a deep internal pelvic muscle? I mean, you can't just ask them if they feel better. You need hard biomechanical data.
Exactly, you need numbers.
Uh,
So they utilized two very specific objective structural measurements at the 3-month postpartum mark. First, they used a perineometer.
what exactly does that measure?
It's a medical device inserted into the vagina that measures the actual physical squeeze strength of the pelvic floor muscles. It measures the force in centimeters of water pressure, or CMH2O.
Oh, I see. So it is essentially a raw grip strength test for your pelvic floor, just measuring the mechanical tension required to hold those organs in place.
That's a great way to put it, grip strength. So that covers the strength aspect.
And what was the second measurement they took?
They used transperineal ultrasounds to measure the levator hiatal area in square centimeters.
The hiatal area being the physical gap, right? The actual opening in the muscular hammock that the baby just passed through.
Yes, because if the muscle is actually healing, tightening up, and repairing its structural integrity, that gap should physically shrink back down closer to its pre-pregnancy size.
Okay, so we have the perfect setup here. Immediate injection into fresh trauma and highly precise biomechanical measurements of both strength and structural size. And we already established that the shallow vaginal mucosa responds beautifully to this stuff. So what were the actual results for the deep bedrock muscles at that 3-month mark?
The data was completely unequivocal.
Okay.
At 3 months postpartum, there was absolutely no significant difference whatsoever in muscle grip strength.
Wow.
Furthermore, there was no significant difference in the shrinkage of the hiatal area between the women who received the potent, concentrated PRP injections and the women who just received the placebo saline.
It failed. The magic bullet just completely misfired.
It had zero statistically significant impact on the structural healing of that muscle.
So if you're a listener trying to make sense of this, there is this massive biological contradiction happening here. Why does PRP rebuild the superficial vaginal wall so successfully, generating all that new collagen and stopping pain, but completely fail to accelerate the healing of the deep levator ani muscle?
It's the big question.
Is it because the cellular architecture is just too fundamentally different? Like a torn skeletal muscle requires mechanical, load-bearing repair, while mucosal tissue just needs blood flow and a cellular wake-up call.
You've hit the nail on the head. That is the crucial synthesis of all this data. It all comes down to understanding the nature of the trauma and the inherent architecture of the tissue you're treating.
Right.
The superficial sub-mucosa. It's this highly cellular, proliferative environment. It relies entirely on epithelial regeneration and angiogenesis. It essentially just needs to build a thicker layer of microscopic bricks.
And that is exactly what PRP's payload of VEGF and PDGF are biologically programmed to do, right?
Exactly. You drop those factors into a bed of fibroblasts, and they do what they do best. They build a thicker, wetter, highly vascularized mucosal lining.
The topsoil gets fertilizer, and it blooms.
But the levator ani is a massive structural skeletal muscle. The trauma it sustains during childbirth isn't just a lack of moisture or thinning cellular layers.
No, it's severe.
It is severe macroscopic mechanical tearing. It's the physical snapping of thick, load-bearing muscle fibers. And that's accompanied by significant damage to the pudendal nerve, which, again, provides the electrical signal that tells the muscle to contract in the first place.
I see where this is going. It's not a dry lawn, it's a snapped suspension bridge cable.
Yes. And you cannot simply pour liquid biological fertilizer onto a snapped steel cable and expect growth factors to somehow physically pull those mats of fibers back together, bridge a macroscopic gap, or instantly repair crushed electrical nerves.
It just doesn't work that way.
No, it doesn't. The cellular signaling of PRP is potent, but the Mogni study proves it cannot magically overcome severe mechanical and structural deficits in skeletal muscle. It lacks the scaffolding. It lacks the neural repair mechanisms.
It really highlights the danger of viewing the human body as a single, uniform organism, where one trendy treatment just fixes everything. Anatomy is destiny. The structural reality of the local tissue dictates the absolute ceiling of what any biologic therapy can achieve.
We so often fall into the trap of wanting a single, elegant solution in modern medicine. We isolate a powerful biological mechanism, like platelet degranulation, and we just assume that because it works on skin or mucosa, it will behave uniformly in cartilage or bone or deep skeletal muscle.
But the architecture fights back.
It always does.
Which brings us to the core takeaway of our journey today. Platelet-rich plasma is an incredible scientifically validated tool, but its efficacy is entirely dependent on its structural environment.
Completely dependent.
Right. When injected into the shallow fibroblast-rich sub-mucosa of the anterior vaginal wall, using a tiny needle, it acts as a regenerative powerhouse. It brings back elasticity, it restores moisture, and it genuinely transforms the quality of life for women suffering from atrophy.
It patches the drywall of the topsoil beautifully.
But when we take that exact same biologic, load it into a 7-inch spinal needle, and try to blindly navigate deep into the pelvic floor to fix the structurally complex levator antemuscles, it falls completely short. It simply is not a magic fix for the severe mechanical trauma of childbirth.
It's not. However, there is one final detail from that May clinical trial that really reframed this entire discussion for me.
Oh, really? What's that?
Well, we focus so heavily on the failure of the PRP to outperform the placebo in those deep muscles.
Right, because that was the big finding.
But if you look at the raw data at the 3-month postpartum mark, the women in the placebo group, the ones who suffered massive foundational muscle trauma and just received a meaningless saline injection, they saw their levator hiatal areas physically shrink back down too. Their muscle squeeze strengths returned to near pre-birth baseline states.
Wait, so they didn't have the magic bullet, but they healed anyway?
They healed anyway. Which leaves us with a rather profound question to consider.
Yeah, I mean, we live in an era where we are constantly rushing to inject the newest cutting-edge biologics like PRP or stem cells into every single bodily injury we sustain, just desperately hoping to artificially speed up the clock.
Exactly. But looking at the silent, unassisted recovery of those women in the control group, are we occasionally underestimating the human body's miraculous built-in capacity to repair its own deep structural traumas without any advanced intervention at all?
It's something to think about. Sometimes the foundation already knows exactly how to fix itself.